Welcome to this afternoon session of the CSJ Symposium 2022, COVID-19's Impact on Communities of Color, Key Findings from a National Study for Congressional Caucuses of Color. My name is Bob Hurto, and I'm the director of the LMU Center for Religion and Spirituality. This afternoon's topic made front page headlines as recently as yesterday. The LA Times had a front page article about the unnerving fact that the Omicron variant, highly contagious, did not spread equally throughout Los Angeles County. Yes, it first appeared in affluent communities where air travel likely had been a factor. But the Times article points out that the pattern of the spread, once again, quote, took a hard turn toward lower income communities of color that had already suffered the most throughout this pandemic, unquote. Very soon, South LA, South Central LA, East LA, and parts of the San Fernando Valley had the highest coronavirus case rates. The Continuing Education Center I direct at LMU has many students in those communities. Many of these students are frontline or essential workers who take the center's faith-based continuing education programs on a part-time basis. For so many of them, the last 2 years has been a continuous cycle of illness, financial hardship, and death. Therefore, when this year's symposium was being planned, I was very happy to see this topic on the schedule. The purpose of our time together is to offer you solid information and resources on the disparate impact that the pandemic has had on the most vulnerable among us, low-income communities of color. It is also our hope that what you hear today will help motivate you to find ways to take action on this significant problem. LMU is very fortunate to have on our faculty a professional who has led a significant national study on the disparate social impact of the COVID-19 pandemic. Very early on, it became obvious that the national statistics showing higher rates of infection and death in communities of color were not giving us specific enough data on this problem. Our speaker today, Professor Cheryl Grills, has had years of experience providing needed data on health and health outcomes in communities of color. She has championed social science research by, from, about, and for communities of color with careful attention to culture and context. Dr. Cheryl Grills is a clinical psychologist with a current emphasis in community psychology. On the faculty of Loyola Marymount University for the past 34 years, she is a professor of psychology, director of LMU's Psychology Applied Research Center, and president's professor in the College of Liberal Arts. She is one of only 6 president's professors at LMU. Dr. Grills is a national past president of the Association of Black Psychologists. She currently serves on the California Reparations Task Force appointed by the governor. She also serves as commissioner and chair of Los Angeles County's Civil Brand Commission for Institutional Inspections, which focuses on conditions and practices within county jails and correctional facilities. She was co-executive director of the Los Angeles County Blue Ribbon Commission on Child Protection, whose work led to significant reforms in LA County's approach to child welfare, including establishment of an Office of Child Protection. I will say a few more things about Professor Grills. It goes without saying that LMU is fortunate to count on such a productive and socially committed scholar. So I'm very comfortable bragging about her accomplishments. But I will also post her full bio in the chat where you can read about her awards, her recognition by public figures, her research interests, her leadership of projects aimed at creating equity in healthcare and health outcomes. Dr. Grills is a research principal investigator on several multi-site projects addressing mental health disparities, social determinants of health, positive youth development, and COVID's impact on communities of color nationally. An important part of her work is in the area of racial stress, focusing on research and training associated with racism, racial stress, implicit bias, and the development of community-based self-help models to address the negative effects of racism on people of African ancestry in the US and globally. When asked about today's presentation, Professor Grills responded, "This is an opportunity to learn, challenge assumptions, and become inspired to help get grounded in information that reflects the lived experience of communities We tend to know only through stereotypes and misinformation. Ultimately, this is an opportunity to deepen empathy and compassion. Please welcome Professor Cheryl Grills.
Thank you very much, Bob. Thank you, Stephanie, and hello, everyone. I hate that I can't see you all in this format, but here we go. I'm going to share my screen and jump right into it. And please, as we're going along, and a question comes to mind for you, please put it in the chat. I will try to monitor the chat with Bob's help as we go, but then we'll also have a question and answer period at the end. So without further ado, let me share my screen. Can you see that okay, Bob?
Yeah.
And it's not in enter mode, right? Okay. Mm-hmm. All right. So, this project is a collective effort by the Alliance of National Psychological Associations for Racial and Ethnic Equity, what we call the Alliance, with support from the National Urban League. And together, we actually led a needs assessment effort to inform the Congressional Caucus and the Native American Caucus about COVID's impact on communities of color. So the Alliance, just so that you know, it's a partnership of national psychological associations and a research institute. And it includes the Asian American Psychological Association, the Association of Black Psychologists, the American Psychological Association, the National Latinx Psychological Association, and the Indigenous Wellness Research Institute. So the role that I played was to respond to the initial call for help from then chair of the Congressional Black Caucus, because they were being called on to make policy decisions in the absence of real data and informative data about COVID's unique impact across different racial and ethnocultural groups. And even as congresspeople or congresspersons, you would think that they would have easy and ready access to all manner of data. But in fact, our federal databases, our national databases are wanting in a number of areas when it comes to understanding any particular phenomenon as it relates to different communities of color. So this needs assessment was designed to fill the COVID-19 data gaps connected to missing or small samples of racial, ethnic, and other demographic groups in the stuff that was coming out in the media and in the journals. Secondly, the lack of disaggregated federal, state, and local race-specific data. And third, the absence of community-informed, nuanced insights and understanding of COVID's differential impact within and across racial groups. And that within groups is something that is really important that I'll hit on in just a moment. But just a little bit more about the background of this study. When we were approached by Congress, they defined the research question. So this was truly a community-based participatory process. And the questions that were posed by Congress were fourfold. They set the research agenda wanting to know about the differential pandemic experiences of communities of color. They also wanted to know, given the last recession in 2008, how our communities would be affected. Third, they wanted to understand the health and mental health effects on communities of color. And finally, the overall general economic impact on communities. So these questions allowed us to actually reveal that for our communities, for communities of color, we were not dealing with a pandemic. We were in fact dealing with a syndemic. And a syndemic is a public health term that refers to multiple interacting conditions or threats that work synergistically to increase burden on a population. And so this perspective revealed the multiple threats faced by communities of color during this COVID-19 pandemic. So what we're dealing with are not new circumstances, but rather circumstances born out of multi-generational racial assault and oppression. And to say it mildly, it was a sobering process for all of us, the researchers involved, as we painfully cataloged and articulated the impact that COVID was having on our communities. And we did, we uncovered a lot. So we were supposed to do a phase 2, more nuanced, deeper assessment in 2021, 2022. But we are still dealing with unpacking all of what we found in this first phase of work and helping civil rights organizations, local community-based organizations, and the federal entities in terms of Congress, the White House, et cetera, understand the implications of our findings. So let me give you a little bit of the methodology and let you know, and I'll try to remember later to put the link to the journal article that was just published, that came out last week, that we all co-authored on this subject of the impact of COVID on communities of color. And we very much in the article focus not just on the findings, but more so on our process and on research methods when it comes to doing some kind of investigative work to understand a phenomenon as it relates to a community of color. That's an important takeaway from all of this. So with that said, the data collection period was from December of 2020 through April of 2021. Our survey sample was 24,944 people across the country. We also collected data or obtained data from the Household Pulse survey that involved 154,064 folks. And then another 2.7 million 3rd through 8th grader children of color to look at some of the education impact. I have kind of here at the heart of the methodology something that reminds us that this data was really to inform Congress so that they make data-driven decision-making and policy-making. And so how did we do that? We had the data for African Americans and Black folks collected by the Association of Black Psychologists that involved 2,480 adults plus 31 key informants. The Asian American Psychological Association collected data for a national sample of close to 5,000 Asian American, Native Hawaiian, and Pacific Islander Americans. And their study, their data, or their survey, I'm sorry, was translated into 9 different languages for Asian Americans and 4 Pacific Islander languages. The National Latinx Psychological Association collected 3,759 surveys. And that was a combination of Latinx adults and youth and immigrants, adult immigrants. And then we have the American Psychological Association, who actually their critical role was to look at the impact of COVID on elders of color using data from the Household Pulse survey. The Indigenous Wellness Research Institute broke a record, collecting close to almost nearly 9,000 surveys from Indigenous folk across the country. This was one of the largest individual surveys nationally, one of the largest number of participating folks from different tribal affiliations that has ever been conducted in this country. And the only reason that they were able to collect this large of a number, as well as the other groups, is because of community participation and engagement. This was truly a community-based participatory process. And you'll see more examples of what I mean by that in a moment. Now, that was the national survey. We also collected data specific to Los Angeles for a number of reasons. But one such survey was with people who are unhoused. So the Social Model Recovery Services provide services to unhoused folks in Skid Row. And we surveyed 711 unhoused folks walking the streets. And then combined that with the Community Coalition survey for primarily South Los Angeles, but it did reach out to other parts of Los Angeles County. 4,447 surveys were collected in Spanish and in English. And then finally, there was the subject matter experts contribution to the process that I'll speak about in a moment. I also do want to mention, this is a very interdisciplinary process. Now, while the leads on each of the priority populations were and are psychologists, many of the subject matter experts were in areas outside of psychology, in areas like economics, education, public health, social policy, epidemiology, health policy, and polling data. So even though I show you the sample up here, this is not the entire sample, because all of our subject matter experts also brought new data to bear. And there was one other thing I wanted to share about them, and it is the other thing I wanted to share is that not only is this interdisciplinary, but I had the benefit of some members of the LMU faculty to participate in this. In particular, Professor Shea Crowder in the political science department and Dr. Michaela Bethune in the African American Studies department played integral roles in different aspects of this project. So with that said, I mentioned that we had these subject matter experts. They included Megan Caufeld in education, who looked at disproportionate educational impacts, particularly academic achievement as a result of COVID. Derek Hamilton, economics professor, did a whole analysis on the pandemic's effect and what he calls the racial wealth gap. Ninez Ponce at UCLA did an amazing job at looking at the toll that COVID has on quote unquote hidden populations. In other words, we need to stop. And if there are any faculty doing research, any students doing research or hoping to do research, we need to stop putting everybody into some large category like Asian American, as though that actually has meaning. Not only is it not helpful, it actually can be dangerous because it can cover up important ethnocultural differences that we need to know, particularly when it comes to policy and practice in health and public health. And so she makes a really cogent argument for disaggregating the Asian American COVID data category in COVID-19 data, and also distinguishing Native Hawaiian and Pacific Islander Americans from that Asian American category. Stella Yee at NYU did some business analyses looking at the effects of COVID closures on businesses like food retail, and the impact that that had, not just on the businesses. People don't understand that there was also an impact on the nutritional, the quality of access to nutritional food. I'm sorry, I just did a 3.5-hour talk right before this one. So my voice is gonna start to give way on me. But in any event, she exposes some things that people had not been typically thinking about when they think about the business impact, particularly as it relates to the Asian American communities in New York. And then Cornell Belcher, the pollster, he actually did the polling with a polling process with us, looking at polling data related to vaccine intent, attitudes about getting the vaccine, and experiences that are associated with the intent to or not to get vaccinated. And so that added another 1,000 or 1,100 people to the survey process that we did a representative sample across the country. And then finally, Elia de la Cruz, who's a researcher in my research lab here at LMU, she and her colleague, Valentina Duque, did a study of mental well-being and gender wage gaps for Black women and Latinx women, with some really eye-opening findings in that regard. So that was our subject matter experts. Just before I get into the data on the next slide, I did want to share that we collected this information, and it wasn't about putting it into a journal. It was about getting it into the hands of people who could use it to make informed decisions. And so as a result, we actually did presentations of the findings, individual presentations to each of these groups that you see here on the slides. That includes the Congressional Hispanic Caucus, the Congressional Black Caucus, the Congressional Native American Caucus, the Asian American Caucus, and also the White House COVID-19 Health Equity Task Force. So they each had, we had audience with each of them over the course of several months. In addition, we presented the findings to a group of national civil rights organizations. We thought it was only going to be about 15 national civil rights organizations. I believe we ended up in the room with 30 plus to receive the information in order to inform their campaigns for their various constituencies. I'm talking about organizations like the Asian Americans Advancing Justice, the NAACP, National Action Network, the National Coalition on Black Civic Participation, the League of United Latin American Citizens, Unidos US, the National Congress of American Indians, et cetera. So the information is out there. I think one of the first groups to immediately use the data to craft some legislation was the Asian American Caucus with our California representative. So let's look at some of the data. I'm going to jump through some of these slides fairly quickly because time is just not on our side, but also so that we can make sure we leave some time at the end for question and answer. I will also mention that there's an executive summary. We laugh every time we say the word executive summary for this project because the executive summary is something like 30 or 40 pages long. That's how much data we're swimming in. But there is this executive summary plus individual reports that are available or going to be available on the website of the National Urban League, as well as on the websites of the different alliance organizations. The executive summary report is out and available. The other reports I'm hoping are going to be out and available in the next week or so. So with that said, let's start with Native Hawaiian and Pacific Islander survey report. And we separated out that data. We did not do an Asian American report. There is one report specifically to Native Hawaiian and Pacific Islander, and then another report for Asian American. And one of our leads on that was Dr. Samoa, who is this amazing physician in New York, who works with a number of different coalitions who are concerned with Native Hawaiian and Pacific Islander health and well-being. So in their particular portion of the study, they had data for 1,262 Native Hawaiian and Pacific Islander Americans. You can see here in terms of ethnicity, the representation across different groups in terms of Samoan, Tongan, Native Hawaiian, et cetera. You can also see that there's a fairly wide distribution across the country. And then also some diversity in terms of the percent that were foreign born. Half of the folks had children under 18 at home, elders at home, and nearly approaching half were essential workers. And then the distribution of age group and who responded to the survey, you see here, a little over half were between 25 and 44 years of age. These are the community collaborators who, without their help, the ability to collect this amount of data on Native Hawaiian and Pacific Islanders just would not have happened. And so this gives you an example of some of the organizations that partnered up with us to get the word out to the community, to get the surveys collected. What we gained from that, Dr. Samoa says, is this is the first reported data on upstream factors affecting NHPI communities. This was a successful community-led effort to gather data. and targeted interventions are possible with this crucial first step. In other words, there's not a one size fits all. It's not a one size fits all experience, and there should not be a one size fits all set of strategies and solutions. A large percentage of the NHPI participants were hesitant about taking the vaccine. People don't talk about that as much in the media, but there was significant vaccine hesitation. 38% of the 18 to 24-year-olds were hesitant. 43% of 25 to 44-year-olds were hesitant. And the smallest percentage were the 45 to 64-year-olds. Trust requires engagement. And what the Dr. Samoa and his colleagues did with the Asian American Psychological Association was to do engagement across all of these different sectors. When we're even though we're talking about a health issue, we have to look at all of these different systems that can weigh in and impact what we're seeing. Now, what did we find? Here are a few examples. COVID had a devastating effect on incomes in the NHPI community. And so you see here loss of employment income by income level. So the greatest amount of income loss was by those who could least afford to have a loss in their income. And then when you look across different groups, not all groups are the same. For example, Native Hawaiian and Marshallese Americans had the most substantial loss of income in terms of employment. But again, not all are exactly the same. And then in terms of age group, it was the younger folks who experienced the greatest amount of employment income. And then the top stressors that people were feeling in relationship to COVID across these groups were financial concerns first and foremost. Well, that now makes sense. The impact on family, physical health concerns, social distancing or being quarantined, mental health concerns, impact on work and community, etc. Interestingly enough, these same kinds of stressors were found across the other racial ethnic groups. Now, one thing that I wanted to lift up is the healthcare access and mental health issues. So for this population, in terms of healthcare access, people were having difficulty seeing a healthcare provider before COVID, and you see that in blue. But look at the difficulty once COVID hit. Overall, 67% of folks were having problems accessing a healthcare provider. And the folks who slightly did better, and I say slightly because it is very slight, were people, the more education you had, the little bit of an advantage that gave you in terms of healthcare access. What kind of mental health concerns? Depression and anxiety were high for this population, but also actually across our groups. And again, it's not one size or one experience fits all. Depending upon your particular ethnocultural group, the amount of depression or anxiety you are experiencing changes. And what this does is it points out to us who we need to be really concerned about in directing resources, directing supports and services, etc. Some of the lessons learned that Dr. Samoa lifts up is that the project demonstrated the importance of partnering with communities. That's a big takeaway for this. If ever there was an example of why you should not do research of your own accord without the collaboration of the community you are studying, this project revealed that. Secondly, the Native Hawaiian Pacific Islander American communities are a low-income group that have low educational attainment. I didn't get to show you that data, but this assumption about the wealth and resources available to these communities are ill-founded. Also, this community are at increased risk of severe illness from COVID due to a delay in seeking health care. And when you look at, which again, I don't have time to go into, some of the death rates and some of the really serious health consequences, there are important differences by ethnocultural groups. And Native Hawaiian, Pacific Islander, American-led community-based organizations fill a critical gap in federal, state, and local government, especially with regard to improving the likelihood of this population or these populations accessing COVID-19 vaccines. So what about the Asian American?
Here's what I found.
Oh, that's not me. my watch wanted to tell me what it found. And so this effort was led for the Asian American Psych Association by Dr. Annie Saw. And this group included 3,736 participants. You see that there's a fair amount of age distribution, but especially 18 to 24, 25 to 44, and 45 to 64-year-olds. There is geographic spread. And in terms of ethnic groups, the highest percentage of participation in the survey were Chinese, Filipino, Korean, Vietnamese, Indian Americans. And then next largest groups would be Pakistani, Japanese, and Cambodian. It was also some distribution in terms of education levels, and with the largest percentage being folks with a bachelor's degree. Household incomes, the most prominent, the largest percent was in the 35 to 99 or $100,000 range. And nearly half were foreign born. 39% had children at home. 28% were essential workers. The only way that they were able to accomplish what they accomplished was the participation of all of these Asian American community-based organizations that got the word out, that hit the streets, that collected the data, that encouraged the community to trust the process and participate, and also helped with the translations. So what's the big takeaway for Dr. Saw and her colleagues is that Asian Americans are facing a syndemic of multiple interacting threats. And in fact, the paper that we all co-wrote makes the conclusion that all of our communities were facing a syndemic of multiple interacting threats. And again, the concept of syndemic helps us to illustrate the multitude of threats faced by Asian Americans during COVID, but also our other groups. And again, many of these threats, such as racism, economic, health, mental health disparities, they're not new. They've been magnified in the context of the current pandemic. So it is from that syndemic framework that we share our COVID-19 impact. So the stressors that were identified, Asian Americans are facing many stressors brought on or magnified in the pandemic, but the most endorsed stressor across all of the ethnic groups are mental health concerns. Over half report stress having to do with mental health or social distancing and isolation. Along with other stressors, many Americans are experiencing. Racial discrimination is at the top, is a top stressor faced by many Asian Americans. We also found that to be the case for African Americans and for the Latinx and which group am I forgetting? I don't remember, so sorry. All right, so as you all know, anti-Asian racism has dramatically increased since January of 2020. And part of this project entailed following up with participants to the Stop AAPI Hate Reporting Center. So they were collecting their data. We teamed up with them. And from that sub-project, we were able to capture the breadth of racism and violence Asian Americans have been experiencing. By far, the most commonly reported incidents were verbal assaults, such as a guy tried to block my way on the street while I was walking, and he pointed to my face and called me, followed by physical assaults. Guys drove by in a truck and spit on me and said I gave them coronavirus. And then being coupled with, or spat on. So Yeah, in black marker, someone wrote G on my car. I'm more fearful to go out on my own now. And this last quote speaks to the impact of anti-Asian racism, some of which, again, we capture in our research. The national study is distinct from other published reports on anti-Asian racism, given the large sample size we have and the multiple Asian languages that our survey was offered in. So in our work, we found that 61% of Asian Americans have seen an increase in cyberbullying, 31% have faced discrimination, and a third said that discrimination is a major source of stress for them. But perhaps most profoundly, we found that 75% of Asian Americans believe the US has become more dangerous for them, a dramatic number pointing to widespread loss of safety, security, and the impact of well-being and mental health for Asian Americans. So Asian Americans have reported to us the economic strains they're facing: lost work, lost income, being laid off soon, and the synergistic relationship between businesses suffering in the context of racism, like in this quote, you know, we will be laid off soon. Economic, or my father's business was greatly impacted, and of course, we are easy targets for hate crime. So economic demands also intersect with other challenges, such as limited English proficiency, as illustrated in a quote from one participant who said, "I needed my parent to help my parents navigate unemployment benefits since English is not their first language." Over half of 55% of Asian Americans reported that either they or someone in their household experienced a loss of employment income since the start of the pandemic, and over a quarter expected someone within their household would lose employment income in the coming months. Overwhelmingly, Asian Americans reported not having pay, receiving pay for the time they were not working. Significant proportions of Asian Americans need help, more help with unemployment services and utilities, and reported needing help with housing. And Vietnamese, Korean, and Filipino adults were most affected by economic concerns, income loss, or needing support. So again, it's not a one-size-fits-all experience, and it's got to be data collected to reflect the nuances and the differences. The current pandemic has magnified health and mental health challenges that too intersect with anti-Asian racism, with economic demands, and other COVID era stressors. So if you just took one stressor by itself, it could have what we call the weathering effect, right? Beginning to wear down your body at the cellular level, which could shorten your lifespan. But then you add all of these others, and it's no longer the pandemic, it's the syndemic. So now in terms of the health and mental health impacts, 44% reported a decline in their health. And younger adults and folks who are low income were especially impacted in this regard. 41% have delayed getting medical care that they need. 41% reported depression or anxiety symptoms, and younger adults and low income individuals were especially, again, impacted in that regard. Nearly a third reported needing help with accessing mental health services, and the need was higher for those who took the survey in an Asian language, which was 37% of folks, or they were between 18 and 24 years of age, which was 41% of the folks, or people who had current symptoms of depression or anxiety, which was 62% of the participants. So these threats interact and compound, resulting in long-term impacts for well-being. Depression and anxiety are among the highest among those with a household income under $25,000. We also found that among our state stop AAPI hate respondents, that 4 in 10 experienced at least one racial trauma symptom following their racism experience. So now let me give you some examples from the Association of Black Psychologists role in all of this. And this is the Association of Black Psychologists as the lead. Their sample was 2,480. The primary sites were these 6 states that you see on the map and listed here. And it was a mix of urban, rural, and suburban areas. So mental health among African Americans or Black folks, and we use the term Black because not everyone who is Black in America has the label of African American. They may be having an immigrant status, for example, coming from somewhere in the Caribbean or the continent of Africa, or they may be Afro-Latinos, which we also found it was important to begin lifting that up because the experiences are different if you're Afro-Latino than if you're not Afro-Latino, but you're Latinx. And so Black is a more inclusive term for the moment. So almost 2/5 reported sufficient anxiety or depressive symptoms to warrant further evaluation by a clinician or a health professional. 40% wish they had more support during COVID, either formal or informal. And as one of our key informants noted, in Mississippi, the community is having difficulty accessing resources for those impacted by COVID. And while the church is distributing food boxes to the community, it doesn't feel like enough of an effort. We also see the intersection of COVID with race-based perceptions, right? Because COVID didn't appear in a social vacuum, it appeared in a racialized society. And so, you know, the threat is, COVID-19's threat is related to both mental health and attitudes about police violence against Black people. So COVID-19's threat, those who perceive COVID-19 more seriously as a threat to their health also were more likely to show symptoms of anxiety or depression. And when we look at the seriousness of police violence, 76% of the respondents perceive police violence against Black folks as extremely serious. And those who perceived COVID-19 more seriously as a threat to their health were also more likely to perceive police violence against Blacks more seriously. However, the seriousness of police violence was not associated with anxiety and depression. Cultural mistrust was another thing that the Association of Black Psychologists looked at. And out of the, well, not sure why that's doing that, out of the 2,480 sample, a total of 1,363 answered all of the questions regarding cultural mistrust. In other words, there was something about those set of questions that people said, we gotta make sure we answer it. And so when we look at the data, did you get the COVID vaccine? Non-vaccinated individuals reported significantly higher cultural mistrust than those who were vaccinated. So what America has done to triggering threat, a sense of ongoing threat in America, has now colluded with the idea about the safety of vaccination. Everyday discrimination was also looked at, and so everyday discrimination is was found to be negatively correlated with optimal mental health, both before and after COVID, and it's positively correlated with anxiety and depression. So the more discrimination that people were feeling, the more anxiety and depression, the more problems they were having. So some of the conclusions from ABSI, there's more data for theirs, but there's a dual pandemic, and it's associated with higher anxiety and depression. Individuals who report COVID as a high threat were more significantly likely to have experiences of everyday discrimination. Black women were especially susceptible to poor mental health during the pandemic. And addressing the impact of COVID-19, you have to also consider the impact of racial violence and the compromised mental health, especially for Black women. Now, let's look at the National Latinx Psych Association and some of their findings for the Latinx community. Their sample was 3,759 folks, 2,300 were adults, 536 were adult immigrants, and 923 were youth between the ages of 13 and 17. When we look at the infection rates, almost half had to continue working in person, even when this meant that they had to be in close contact with others who might be infected. So those of us who had jobs where we could shelter in place and continue to work, that was a luxury that other people didn't get to have. So, and what we found in the survey was that 1 in 5 had tested positive for COVID, but no longer had symptoms. Another 20% said that they had COVID-19 symptoms, but they were never tested. And more than a quarter knew someone who died of COVID. In fact, someone in our own lab lost 5 family members to COVID. In terms of economic impact, the close to half had a reduction in hours or were furloughed. 2 in 5 were laid off or had to close a business, and over 1 in 3 experienced difficulties in paying their bills. In terms of mental health impact, more than half were having more mental health problems during the pandemic. 6 in 10 essential workers reported having more mental health problems during the pandemic. And I have to tell you, I get angry whenever I see people in public being impatient, disrespectful, rude, or acting as though our essential workers are invisible, when these people are literally putting their life on the line so we can go and shop for groceries, we can go get some medical attention, we can get something from a restaurant. And over a third of the participants were having moderate to severe symptoms of depression and anxiety. Now, in terms of the mental health impact for the adult immigrants, although 63% of the immigrants reported they were having more emotional problems, 1 in 4 were unable to get mental health care or support. 1 in 3 were with US citizenship were experiencing moderate or severe symptoms. 2 in 3 without citizenship were experiencing moderate or severe symptoms of depression and anxiety. So our immigrant population is at even more risk and is bearing an even larger burden of COVID's and negative impact. In terms of the youth, about a third reported feeling sad and depressed most or all of the time. Now they have to then go to school via Zoom and then try to be academically focused and achieve. You also see that there was slightly higher rate for girls relative to boys. And in terms of coping, how are our youth coping? Our Latinx youth, 1 in 5 used drugs or alcohol. 33% were sexually active and having unprotected sex. And more than half turned to food to deal with the pandemic. But that's in the midst of also having food insecurity, right? So in terms of men, 53% of the adults were experiencing food insecurity, and 51% of the women were experiencing food insecurity. And I will say that across our groups, and you'll see this in the executive summary if you pull it up online, is that food insecurity was a huge problem across all of our groups. For example, 43% of the African-American population needed more help with food during the pandemic, and 80% did not live within a mile of a food bank. And that's a problem, especially if you're in a place like California and Los Angeles, where public transportation is not, is not what it should be. All right, so in terms of adult immigrants, 47% basically of all Latinx immigrant adults had difficulty getting enough food or healthy food. 1 in 3 immigrants with US citizenship were food insecure. 2 in 3 immigrants without citizenship reported food insecurity. Again, our immigrant population is in a much more vulnerable state. In terms of our youth with food insecurity for Latinx youth, 53% were food insecure overall, and you see that it's slightly higher for girls than for boys. All right, so now let me give a few examples. I'm trying to keep track of my time of the Native American or Indigenous findings. That work was led by the Indigenous Wellness Research Institute at the University of Washington, who also did a massive amount of collaboration. And they clearly credit the fact that they broke a record with collecting survey data with the Indigenous population to their strong collaborations with national, regional, local, and tribal community groups, and their advocacy network organizations across the US and Hawaii, who work closely and tirelessly with recruiting and advertising the study. So in terms of an overview, it's one of the largest national studies. It's raising the visibility of Native experiences, and that's critical during this pandemic when we tend to ignore the unique needs of different communities of color. And we found that typically for Native American communities, they were hit exceptionally hard, yet they remained, you don't hear a lot of discussion about them on the news. So they remained largely invisible, undercounted for sure, and misidentified in COVID-19 public health surveillance data. So those inadequate systems of reporting, the data collection methods, and analytic approaches led to significant gaps in understanding what was happening for the Native American community and the Alaska Native communities in this country. So what were some of the greatest sources of stress? Mental health. So I mentioned food insecurity was important, but mental health across the board for our different populations was a concern. So it's mental health, physical health, finances, the impact of social distancing on maintaining cultural norms, the impact on work and on family members, and being able to fulfill caregiving responsibilities. The confluence of environmental and socioeconomic inequities and also pre-existing conditions interacted and created the syndemic that was experienced by the Native American community. And so you see this whole series of things interacting with one another to the detriment of the community, where you end up with 69% social distancing and experiencing PTSD, 63% not having enough food, and they were depressed. But nonetheless, people practice their cultural norms and principles and values and activities and rituals. And that was the case for the Native American groups, but also very heavily so for many of the other ethnocultural groups. It is in fact true that culture is protective, culture cures. So what did people need the most help with? And that NLPA shouldn't be up there. This is Native American. Sorry about that. 37% needed help with food. Again, the food insecurity concern, employment, health services, housing, and utilities was another big one. Utilities and Wi-Fi access. And especially during the pandemic, people needed more and more access to the internet because that's how you found out stuff. That's how you registered for things. That's how you did if you were able to get a doctor's appointment, it was telemedicine, et cetera. So imagine then that we had in our communities a whole host of people who did not have Wi-Fi access or were having problems with utilities. For example, 24% of Native Hawaiian and Pacific Islanders had problems with Wi-Fi or internet needs. 23% of African Americans, 25% of the Latinx community, 37% of Native Americans, and 20% of Asian Americans. So there was also high levels of collective loss during COVID. Now, research has shown that being socially connected and having strong family networks are strong predictors of resilience during natural disasters. And that can serve as critical psychological, social, cultural, and spiritual sources of support when you're in the midst of collective crises. In addition, the pandemic created ruptures in support systems and families when they were experiencing high levels of COVID-19 morbidity and mortality in their communities. Over half, 54% of participants in this study had someone in their family or social circle get sick with COVID, and 1 out of 10 had someone in their social circle die. Now, any loss is painful, any loss is important and critical and major. But when you think about loss in the Native American community, you have to add one additional caveat because of settler colonialism and the horrors meted out against the indigenous communities here in this country. So that if an elder passes, it's literally like you may have just lost 4 or 5 libraries. They have the language, they have the cultural rituals and tools, they're the standard bearers, the cultural brokers and cultural keepers. And so you lose one, you're losing actually something that is actually much, much vaster and more far reaching. Mindful of time, so I'm going to continue. So there are disruptions in connectedness. Real concern during this project by the Indigenous Wellness Research Institute and the community partners. Tribal communities took immediate action and created some of the most robust efforts to minimize the spread of COVID through like strict stay-at-home orders, lockdown of roads to prevent outsiders from entering reservation communities, and shelter-in-place orders, et cetera. The response to the pandemic has led in part communities and families to kind of turtle up, as they say, intensifying strong tie interactions among family members and clustering. People were clustering in pods and small family groups or households. Nearly half of the participants reported high levels of isolation from their social networks and extended family that disrupted their ability to provide care or increase their sense of loneliness. And almost half were unable to visit or care for a family member, and 1 in 3 had to live separately from their family during the pandemic for health, safety, or job demand reasons, and over 1 in 5 often felt isolated from others. Now, again, this would be a problem for all of us, but if your culture says and shows you that the best way to maintain your physical health, your mental health, your spiritual well-being is to be regularly connected to others, then you can understand just how devastating shelter in place could be for those communities. So naturally then there were adverse mental health impacts, including PTSD related symptoms, depression, anxiety, and then substance abuse related issues. And 24% of folks seriously considered suicide in the past month when we were surveying them. But to only look at the harm from COVID is to only to tell half the story. So the other part of the story is the resilience. And all of our community groups decided that we were not going to do the typical research and only point out, okay, what are the problems? What are the needs? What are the harms? We also wanted to know, how are our people actually managing this? What does our resilience look like, and what can we attribute our resilience to? And so all of the groups actually identified what ended up, to our surprise, looking fairly similar as people of color about what we found to be important to our resilience. Not because we are theoretically conjecturing about this. This is what the community said they actually were doing. to manage the stress of COVID. So for the Native American community, 36% prayed, 33% used traditional medicine and healing practices, 31% smudged or cleansed themselves spiritually, 29% prayed for spiritual support from God and the ancestors, 27% reached out to elders or respected Native health leaders to help them cope with the stress, a quarter talked to clergy or spiritual advisors, and a quarter worried about the impact communities and related loss of traditional knowledge and keepers and elders would be. Now you say, well, how's that coping? Because then that inspired them to really dig deep in and to do a deep dive into reclaiming, relearning, deepening their understanding of their cultural traditions. In terms of these resilience and coping strategies, in other groups, we saw very similar things. And I'm going to show you some examples specific to the Los Angeles sample, but just in terms of positive coping strategies, that many of which were culturally based, for the Asian American and the Native Hawaiian and Pacific Islander communities, 73% in each group talked with family and friends as a primary source of coping. 43%, for example, of the Native Hawaiian and Pacific Islander folks engaged in religious and spiritual practices. For the Latinx community, 54% talk with friends and family as a way to cope. In other words, people didn't take the saying literally. They instead looked at, it's not social distancing, it's merely physical distancing. And so then people use whatever technology or means they had at their disposal to maintain physical distancing, but they ratcheted up their social contact with family and friends. And so so for nearly 1 out of 5 people, outdoor physical activities increased during COVID. For the Native American population, people were getting outdoors, walking, doing outdoor-based activities like gardening, building, and painting, spending time on ancestral lands and cultural sites, hiking, camping, spending time on the water and fishing. They also were doing things like cooking together more as a family, exercising and taking walks, working more as a family on Native art and crafts, as a family doing that responsibility for the well-being of others, cultural mandate, which so helping other people in the community, and then practicing their tribal languages. So there's a reason to be hopeful about vaccination, but there's a lot of work to be done. 21% of the Native American sample reported already receiving the vaccine. That was a year ago. So we're in a much different place now. But of those who are unvaccinated, 27% reported being unlikely or extremely unlikely, and 24% unsure about whether or not they would get vaccinated. So it was clear that there was more work to be done, but that work needed to be grounded in the culture and context of Indigenous communities. So what does the data tell us? The data tells a distressing story. Native Americans and Alaska Natives are dying of COVID at higher rates and at younger ages than other populations. Native adults between 20 and 29 had the highest COVID mortality rates, which is concerning because that's the childbearing age. Chronic and pervasive systemic health and social inequities place American Indians and Alaska Natives at increased risk of getting sick and dying. The pandemic constitutes yet another adversity that they must face. And the data also, though, reveals a story of hope, perseverance, resilience. And Native communities have tremendous resilience and survivance strategies. And we need to actually support cultivating that more. So in the service of time, I'm going to go on to and conclude with this. I loved this when Karina put this particular image up, and she had taken it down when we were going to do the White House briefing. And I said, no, leave it up. The US needs to see this. Smallpox, all right. Now COVID, all right. we're still here, right? We're still here. So to end all of this, I want to just give you, so what's happening in Los Angeles? And again, we did an additional deep dive into the Los Angeles context, and we actually shared this data, not just Los Angeles, but California specific data with the a collective of California departments, like the California Department of Public Health, Social Services, on and on. And what we did was we used the same set of core survey items that were included in each alliance organization's national survey tool. And then we added some items. So I didn't mention that in terms of methodology before, but all of the groups collected the same set of about 16, 17 items. And then from there, the remaining items were specific to what that group felt was important to query about for their community, given their community's culture, context, and history. Again, one size does not fit all, including in research methodology. So the two groups in California I mentioned before were the social model recovery folks looking at Skid Row, and the Community Coalition. And so we covered the final response rate. We had 5,087 participants, but we actually only analyzed the data for varying reasons on 4,447 participants. 56% of them were residents of South LA, covering about 10 or so zip codes. And so this is the demographic breakdown. You'll see a little bit more female than male. Nice age distribution, more Latinx than African American, and more folks in very low income bracket. So since the pandemic, what did people in LA need help with? Food. Once again, how are we supposed to be one of the greatest nations in the world, and we have so many people who are food insecure? Health and mental health services was another thing that people said they needed help with. Housing, utilities, internet and Wi-Fi, and being able to pay their phone bill or their cell phone bill so they could keep connected. What's been the greatest source of stress since the outbreak? Mental health, physical health, financial concerns, the impact on others and the community, being stressed because others were not wearing their masks, impact on work and housing, social distancing requirements, and the impact on their children. And so what have we done to cope in LA? Again, cultural principles and practices came out. 74% reaching out. Yes, I'm physically distanced, but I'm going to remain socially connected, especially for African American and Latinx folks, but especially the Black community. Listening to music was a way to manage stress. Now, here's a little secret. African cultural wisdom and African science knew that, and we're starting to catch up with that in terms of some research in psychology and in other disciplines about the healing nature of music. It's not just pure entertainment, it actually has a healing component. And then there was exercise, hobbies, increased TV watching, which may not be so great, internet and TV searching, eating more, so that comfort eating, religious or spiritual practices, and being outdoors. But here's the problem with being outdoors. We don't have much recreation justice in South Los Angeles and in East LA and other low-income, primarily communities of color. And so getting outdoors and doing more in terms of exercise, et cetera, can be a little challenging. What about our homeless population, our unhoused? So 47%, nearly half were African American, a quarter were Latinx. Most of the neighborhood area was Skid Row, but we did also get input from folks who were unhoused in Boyle Heights. The age distribution, predominantly 45 to 64 year old. and folks primarily with a high school education. But we also had folks with, some college and trade and tech training, mostly male rather, and distribution in here in terms of, whether they were seniors, they had adults. And you say household, and that sometimes just means where on the street are you camped out? Where's your tent, right? And so what do we see? The top sources of stress, number one, mental health again. Number two, financial concerns, then physical health and housing. Now, let me just say something really quick as I begin to wrap up so you can ask questions. People are saying repeatedly across our groups that they need mental health support and that their mental health was one of their greatest sources of stress. Newsflash, we are in a bit of a conundrum because Western psychology has not done its work to make sure that the theories and the intervention strategies it has developed actually speak to the needs of different ethnocultural groups. We have created these one-size-fits-all interventions, cognitive behavior therapy, and I'm not going to start listing them all, but they were not adequately tested in many cases across all of the different ethnocultural groups and racial groups that you've been hearing about today. But nonetheless, folks are forced, if they're going to get treatment, to subject themselves to that. And then if the treatment doesn't work, we then blame the client and say they weren't ready, they weren't verbal enough, they were inconsistent, etc. So the strategies that people were using, you see similarity, what I've already said, the music, the listening to others, and exercise. The most frequent thoughts that people were having, I didn't get to share this on some of the other groups, people were having a lot of thoughts about historically traumatic events that were similar to COVID. In other words, COVID was triggering other traumas that people have know about and have experienced. People were feeling isolated and alone, etc. The most important stressors, the top four, access to food, impact on the community, transportation, and the social distancing. Imagine how you gonna quarantine and you're homeless, right? So I'm gonna end this now. Not sure why this is going that way. I don't have really time to go into the headlines for the different subject matter experts, but to suffice it to say, the wealth gap is a huge issue, and we need to actually start thinking about understanding the wealth gap, not just looking at income level. The polling reveals some important ethnocultural differences. Stella Yee's epidemiological data reveals some important missing data for different subgroups, if you will. Nines Ponce, again, raised the issue, articulated the need for disaggregating data. Students of color most impacted by education disruption. And Elia de la Cruz and colleague actually showed that women, Latinas and African-American women bore and continue to bear a higher load on the impact of COVID. So I'm going to stop share there and just open it up for questions.
Thank you, Dr. Grills. I thank you so much for this presentation. You've clarified so much about what the experience of COVID has been in communities of color. I have first a question about the end of the process of this study, and that was you took this your report, your findings, you and your colleagues took your findings to Washington, to the White House, to the Congressional Caucuses of Color. What did you find in their reactions and reception and questions that was most hopeful? And what did you find that perhaps the areas that most challenged them?
So I guess I would say what was most hopeful was that for each of those groups, for each of those race-specific caucuses, if you will, And for the White House task force, COVID task force, and the civil rights organizations, people showed up and they listened. They realized that there was a knowledge gap. Some were not amused at how poorly our government collects data as it relates to people of color. And I think I was most inspired by watching, I believe it was Representative Chu, who, when we did the presentation, Annie Saw led that one, and we did a much deeper dive into the findings for the Asian American, Native Hawaiian, and Pacific Islander American findings. Barely got off the webinar, and was already looking at, okay, how does this then shape or change the legislation here? We need to fold this in over there. Saw the same kind of thing, with the some of the civil rights organizations saying, how does this, what are the implications of this for the campaign that we're working on? Didn't realize that, those kinds of things. But I also think our findings kind of corroborated what the White House COVID task force was seeing in certain instances, but we pushed the envelope a little further. So it would be nice to disaggregate data. It is unconscionable that you do not disaggregate the data, right? Because what ends up happening is you're making gross assumptions about the generalizability of findings for certain ethnocultural groups as though they apply to all. And you've seen already from some of the slides, there were some important differences.
Did you find, you mentioned, you went into some detail on vaccine hesitancy in the Native Hawaiian Pacific Islander part of your presentation. I know you're pressed for time here, but I'm curious to ask if that was also taking that in cultural context and historical context in all the communities, how big a part of that was that problem in the studies?
Yeah, so I wish I had had time to actually go into the Cornell Belcher survey. I mean, poll. It was a national poll because he looked at we actually, I think it was an education moment for him. I mean, he's an experienced, highly known, constantly on MSNBC and CNN and Meet the Nation and all of that, Face the Nation and all of those shows, as a highly regarded pollster. And we had to get him to change how he was doing certain things in order to uncover the nuances and the differences. And true enough, for example, the polling data provided some really important differences within the Asian American, Native Hawaiian, and Pacific Islander population around vaccine hesitancy. In terms of, so certain groups were more hesitant than others. And you would miss that if you didn't disaggregate the data. The other thing that he found was that he tested, and we got him to do this as a polling tactic, test certain ideas about like vaccine messaging that would work. And in fact, different ways in which you phrase things for certain communities, if you align it with their cultural beliefs, will increase the likelihood of vaccine, intake, et cetera. And so that was a really, really helpful thing to be able to see.
Did the study at all look into representation within the healthcare community as well? And I imagine that could be an issue in terms of people's willingness to engage with the healthcare system to begin with, or was that not a big factor with COVID?
Yeah, so one of the things, and again, this is the Belcher poll, and we got him to include this. He included questions about experiences of racism within the medical profession, and looked to see how did that correlate with vaccine hesitancy. And lo and behold, those who had the highest level percentage of experience with racism in the medical profession as patients were also more likely to be vaccine hesitant. So what it exposed is that every time I hear this on the news, I just scratch my head and say, but wait a minute, are you sure you got the full picture? When people say, trust your doctor, talk to your doctor, trust your doctor. Well, if you're from a community of color, your doctor may have been the one exercising some massive implicit bias that cost you, some of your health.
Yeah.
So my doctor is not going to necessarily be the first person. Now, my doctor personally, my primary care physician, yes. But some of the specialists I've gone to, absolutely not. I had to sit them down and say, okay, look, this is the plan we're going to follow. We're going to run these certain tests. We're going to then have me come back in after this amount of time. And then we're going to, and it's like, yeah, I did my homework. You were not giving me the best care possible. So why would I just automatically trust you?
Yeah.
There's a broken relationship between communities of color and the healthcare system historically in this country.
You've given us much to ponder and much to be hopeful about, but also so much that is concerning. That the problems are very, very deep and require long-term solutions and investments. I imagine there's an appetite in Washington for interventions that will address the conditions of the pandemic directly, like even improving the messaging on vaccinations, right? But on the other things, on housing, on income, this is where we are with where we are in our society. You've held up a mirror to very serious issues that have very life and death outcomes.
Right. And I think one of the things we were trying to make clear, and which is why we also wrote the journal article, focused less on just showing all of the findings, but more on how we need to be doing research differently, but then also how we need to understand that this was a syndemic, so that you can't look at COVID-19's impact on our communities in isolation of the history and current context of racism, structural racism in this country. And so that then invokes what are the issues with respect to housing? What are the issues with respect to education? What are the issues with respect to healthcare access, et cetera? That you have to look at the intersection. And we have to stop doing all this research in silos. I, as a psychologist, could never have come up with the information and the insights from epidemiology, public health, economics, education. We need to have that interaction. And I have to say, I was in a meeting a couple of days ago with folks who are representing Stanford. I believe it was Stanford. And they were describing a particular research endeavor that they're engaged in. I said, LMU, we need to catch up. They, on a single issue, had at least 15, 20 different departments in that university, all contributing. It's around the issue of the, there's California is about to launch something related to guaranteed income for youth in foster care. And the team that got pulled together, so I'm an advisor to this research process. The team from Stanford was just phenomenal in terms of the interdisciplinarity. And I'm begging LMU, let's look at that. Let's start looking at research projects, research questions, and pulling together teams from different departments. Now, in our lab, we do that in general. Our lab is very interdisciplinary, but we're kind of like a unicorn in that respect, where we should be one among many doing that. And I have to say that this group from Stanford, I think, is going to be a defining group around guaranteed income and the impact that that can have on transition age youth coming out of the foster care system.
We've had the call out for questions, but we don't have any from the audience at this moment. Do you mind if I give you just a wonky question? I'm just curious, was gender a significant factor in any particular group? The outcomes were, and could you comment?
Yes, gender was a factor. So I'll start with Elia's study. In Elias de la Cruz's study on women and the extra burden that, who carries the burden of COVID, especially during the very strict shelter in place.
Yeah.
The burden was heavier on women in terms of the amount of hours above and beyond what fathers and husbands and men in the household had to contribute. The women then also carried a heavier burden of depression and stress. The other thing that where gender came up is in the polling. So in the Belcher poll, there was greater vaccine hesitancy at that time among Black and Latina mothers.
Wow.
And yeah, interestingly enough. And then in terms of some of the other findings, there were, I can't remember, there's so much data, I can't remember them all, but everybody did do a kind of a scan of gender differences on like needs, major stressors, ways that people were coping, etc. And so, just like race matters, gender matters.
It's interesting, the vaccine hesitancy for Black and Latina mothers, you said, because again, that was sort of the assumption I would make is that, have to do with the protectiveness of motherhood. But I wonder if the research found any other factors as well.
So we haven't done additional analyses of the poll data. We had, I think it was like around 1,100 participants in this randomly selected national polling process. And so we haven't done the additional analyses yet. That's what the teams are doing now. That's why I didn't ask them to join me today, because I knew everybody's just like, okay, we just caught our breath from getting the reports out for each individual group as well as the executive. We just got the journal article out and accepted, and now it's available. And so now it's going back to do those additional analyses.
Very good. I'm going to put the center's email address into my own center's email address into the chat, just in case, and we can provide links that you can share with me later to the executive summary and such, and the studies as they come out.
Yes.
So that's our address. Also, the chat is filling up with folks who are very, very happy to have joined us today and have heard so much, learned so much about this very significant study and this significant social problem. Thank you very much, Professor Grills. It has really been a great pleasure to be with you this afternoon. You never never disappoint, I say, in presenting really plenty to ponder. Thank you, and for this afternoon session, we're going to close now. Thanks. Bye-bye now.
Thank you. Bye-bye.